Guten Morgen, meine Damen und Herren. Vielen Dank für die Fans und die Mehrheit. Now continue in English. Okay, this is my presentation about the studies of the CHARCOT group. The theory of CHARCOT is clearly recognized. Diabetes, rheumatoid arthritis, and so many patients with rheumatoid arthritis with CHARCOT group. Idiopathic peripheral neuropathy, total syndrome, sickness of vitamin D deficiency. And we use techniques like similar to the technical engineer to control the life's diet. This kind of device can be used in the food. This is our food design structure. It's quite similar. It's similar that the engineers, the architects use the same principles that we can use. Well, let's put on helmets and go to work. The principles is to construct the CHARCOT food design. The CHARCOT joint can be fused with stronger friction with extra leverage. That means that we used to use thick long screws or nails, and sometimes require require double time to consolidation than normal patients. If you have normal patients, spend more or less 6 to 8 weeks to heal the CHARCOT food patient versus the double time. Well, surgery can be undertaken with preserval of the open ulcer. Sometimes we wait to the ulcer close, we can wait forever because it's quite difficult to close the ulcers with the fluids in the body. This is more important for me. This is one of the more important things, is that patients with CHARCOT food should be controlled with glycemia and the glycosidated hemoglobin. Sometimes this is quite difficult because the psychological phase of this phase is quite difficult. This is a pump, or insulin pump, that can protect perfectly the levels of the glycemia. And this is the rebar that we use. This the nails, femoral nails, bolts, normal screws. Sometimes we use the A-frame, sometimes PCT-SF. For us, gastrocnemic resection is very important because most of the patients have some requirements of the intracranial bone, and this can produce the sinking of the fluid and produce the ulcers. Well, this is one of the patients, a 54 years old man with diabetes with this location. He came from Venezuela to Spain, and this is the preparative. This is the X-rays. You can see that this location of the ankle. There is no itial bone. There's ulcer. First of all, we put an A-frame to decompress the bones, and then we operated him to introduce a ball in the middle column. The ball is outside, but I corrected it. I put a synthesis nail, ankle nail, and remove the ulcer. 1 month after the surgery, the patient comes back to the office and with this kind of fracture. Okay? As other colleagues say that I changed and put a femoral femoral nail for the neuropathic fracture. Okay? And we can resolve the problem with this kind of surgery. This is the healing of the bones. And this is the preoperative video and the postoperative video. The next patient is a 60-year-old man with with this kind of posture. Okay, I draw the lines of the bone that's we operate this patient, first of all, we use the two external facial to decompress the lymph fluid. Then we use the midfoot ball. Okay, and for the ulcer, we prevent of the ulcer and introduce pills with antibiotics and close the ulcer. I don't have any problem with this kind of surgery because if you control the infection and do completely the removal of the ulcer normally usually close. But in the last cases that we operate as this kind of patient, we remove the cuboid bone because sometimes the cuboid is the worst problem for this patient and the recurrence of the ulcers of the patients. This is the patient with X-rays with screws and bolts, compact bolts and screws. This is the picture after surgery. The ulcer, the blood vessel was closed completely. It's the right side, it's not left. Still is working. Normally. This one, other patient that is 45 years old, diabetes, nephropathy, liver transplantation, charcoal fluid, ankle. This is the first X-rays is CTS before. Well, we put screws, compact screws and tunnel screws. He works normally. And after 6 years, there is a collapse of the hind foot with the tail's bone disappeared. In the middle, he was amputated in another place in Spain, another foot. Well, this is the preparative pictures. And introduce called nail. It doesn't work. I'm sorry. And now after surgery, you can work normally. This is no CHARCOT patient, but I'm doing this because for me this is the future. In my country, the people don't like to match the amputees, or don't like to match the joints. For instance, to fuse the animal or something like that. This is a post-traumatic patient with osteomyelitis of the canvas. And I think in CHARCOT patient with good blood circulation, there is no problem to do this kind of surgery. This patient is a post-traumatic patient, as you say. He presented with osteomyelitis for more or less 1 year of evolution. We removed all the posterior part of the calcaneus. Then introduced all the tissue that was infected. Introduce a piece of bone, a piece of cement with antibiotics, and after 6 weeks, we take it out, the tubular bones with a pedicle. We make a double graft and suture to the posterior artery and vein. Okay. And this is the X-rays after surgery. Okay. Now the patient is completely well. I don't have the video, but maybe the next presentation I have. But this worked very well. And I think this is a good way to avoid amputation or to work on deformity foot. In conclusion, we must create a stable structure, balance the muscle function. I think more a civil engineer than a doctor to say the truth.